what is dementia? You hear the term tossed around a lot. And dementia is basically a generic kind of umbrella term that describes changes in memory and thinking that are acquired, meaning that you weren't born with them. They have happened to you over time. They have to affect memory plus a different area of thinking. So that could be language, trouble coming up with the right words you want to say. It could be executive function, the front part of our brain that plans and organizes and helps us, plan out our day or follow a recipe. It could be changes in something called agnosia, the ability to recognize people or objects for who or what they are. And if you have memory loss plus one of these other changes, and it represents a change from how you used to be, and it interferes with your social, occupational, or daily function, your ability to complete the things you normally do during the day, then it's dementia. So Alzheimer's disease is the most common cause of dementia. It accounts for at least half, if not more, of cases of dementia, and is characterized by, if you look under a microscope, very specific findings of plaques called amyloid and tangles called tau, and you have to have those in the brain in order to have a true diagnosis of Alzheimer's disease. A lot of people use Alzheimer's, and senility, and dementia interchangeably, but the truth is Alzheimer's is just one cause of dementia. It just happens to be the most common. Right now it affects over 5 million people in the United States. That number is increasing as we live longer because age is by far the biggest risk factor. And it affects about 10% of people 65 and above. And by the time we get to 85 and above, it's about almost half. So aging is our biggest risk factor for that. However, I did read this morning an encouraging article saying that the rate of dementia overall in the U.S. has gone down in the last 25 years by about 24%, because we're understanding things that cause it, we're learning about ways to combat it, we're educating ourselves. As a whole, we're educated compared to how, particularly women, back 100 years ago didn't have the opportunities that we have now for higher education, and things like low education level, just low overall brain use over your lifetime is also a risk factor. However, there are lots of other things that can cause dementia besides Alzheimer's disease. There are numerous neurodegenerative disorders. You mentioned Lewy body disease already, which is a relative of Parkinson's. Lewy body dementia is a very specific diagnosis that's characterized by, and I have a slide later, so you don't have to write that down, by Parkinsonism, prominent visual hallucinations, and cognitive changes that all occur within a year of each other. There's frontotemporal dementia, where people have real sparing of memory issues, but have very prominent behavior problems, inappropriate kind of behavior, or very severe apathy, where they're just content to sit and look at a wall. Chronic traumatic encephalopathy, which football players get from repeated head trauma. All of these have different pathology that we can see under a microscope that makes them one specific diagnosis over another, in addition to the different symptoms that we can see. The second most common cause of dementia after Alzheimer's is vascular. These are stroke-related changes. Some people have lots of little strokes. Some people have a couple big strokes in strategic areas that can cause a dementia syndrome. Usually with vascular dementia, it is a little bit spottier because it just depends where you have strokes as to what kind of symptoms you have. So it's more of a mixed bag of further in the brain to the parts of the brain that matter, do we consider it as a cause of memory problems? You can get dementia from drinking too much over a period of many years. You can get a reversible dementia from vitamin deficiency, like B12. If you have low B12 over many years, again, that can cause a picture that looks very much like Alzheimer's, but when you treat the B12, it improves. You can get dementia from brain infections, from certain autoimmune diseases, like when people have severe cases of lupus and other things that actually affect the lining of the brain. And then something called hydrocephalus, which is water on the brain, where people have a very specific syndrome of memory loss, a different kind of gait disturbance than Parkinson's, because in Parkinson's usually you shuffle and you keep your feet close together. In hydrocephalus, usually it's a wide-based kind of staggering gait, and people have urinary incontinence. So if you have those three things, then hydrocephalus is something to consider, and that is actually treatable by putting a shunt in the brain that drains off the extra fluid. So dementia, now you kind of understand, dementia and Alzheimer's aren't interchangeable. There are many things that cause it. Now, dementia is something that we can see in Parkinson's disease. I mentioned in Alzheimer's, the problem is amyloid primarily. In Parkinson's disease, even without dementia, you have what are called, if you look at your brain under a microscope, you have something called Lewy bodies deep in the basal ganglia. That's the motor area that's responsible for the dopamine pathway and the movement issues that you have. Usually in Parkinson's, the Lewy bodies are restricted to that area. But you can get a type of dementia called diffuse Lewy body disease where they're throughout the whole brain. And that's the kind of dementia that I mentioned earlier where the symptoms all occur within a year of each other. That's the most sciencey slide. It gets better from here, but I just thought that you should be able to see that. So some common symptoms of the dementia that can be seen in Parkinson's. Changes in memory, obviously, although they're not usually as prominent as some of the others. Difficulty with concentrating and trouble with judgment. People can have trouble interpreting visual information, kind of looking at what they see and either understanding what it is that they're looking at or kind of figuring out, I say that my husband has this. A lot of men do. It's like, can you give me the coffee cup? I don't see any coffee cup. It's like the white one right in front of you with the ketchup in the fridge. It's like, oh, because it's behind, oh, well, I didn't see it. It was behind this. Right? So, but that happens to, hey, Dr. Howard. That happens sort of with excessive frequency and in even simpler circumstances than the one I just described. Muffled speech is common. Part of that is motor related, but it can also just be part of the language difficulties that can go along with dementia. You can sometimes see things or believe things that aren't true. Now keep in mind, and this is very important, and I'm sure that your esteemed doctor here has taught you this, since most of you see him, that the Parkinson's spectrum is one of dopamine. And so when you treat the motor symptoms, you can increase dopamine and cause hallucinations. Drugs that are used to treat hallucinations can worsen the motor symptoms because they're all kind of on the same spectrum, which is why we have to be very careful and use tiny little itty-bitty doses of the antipsychotic drugs, because anytime we try to target those symptoms, we can worsen the motor symptoms of Parkinson's. So it's a very delicate balancing act. But within the context of Parkinson's disease dementia, slightly more often than we do in Alzheimer's, although they can be common in any kind of dementia disorder. Depression, not necessarily major depression, but sort of vague depressive symptoms can be part of the dementia picture. Irritability, anxiety, so there's mood symptoms that sometimes go along with it as well. People can also get disruptions of the sleep cycle, acting out dreams, and again, some of these are part of the disease process itself, and some of them can be due to the medications that we use to treat it. Now this is where I don't want you to freak out, okay? This is important. So while statistically, if you look up, you know, on Google or wherever, you'll see statistically that about 50 to 80% of Parkinson's patients will end up eventually with dementia. But there's a lot of caveats to that. It also means that 20 to 50% of people won't. So, you know, if you want to look at a positive side of things, that could be up to half, will not. It's much more common for people to develop Parkinson's dementia when they're diagnosed older. If they're above 70 at the age of onset of their symptoms, then it's more likely. But to be honest, we don't fully know if that's a consequence of the disease itself or the fact that we're dealing with an older brain that's at risk for other pathology too, like Alzheimer's. Because as I explained, age is the biggest risk factor for that. Sorry. People whose Parkinson's syndrome include things like hallucinations, a lot of sleeping throughout the day, and very severe motor control problems throughout their course are more likely to develop dementia than people who don't have those symptoms. People who do not have predominant tremor are at higher risk, and people who have like early onset Parkinson's before age 50 almost never develop dementia. So if you're diagnosed when you're very young, you've had it for a long time, your likelihood of getting it is lower. But despite, and this is where I said I didn't want you to run screaming out of the building because I'm not trying to scare you, I'm just trying to help you understand. There's a lot of things that we can do. You mentioned Lewy body earlier, and again, I want to just review. Because these are cousins, they're, you know, at the end of the day, sort of on the same spectrum and ultimately end up looking the same when they go on long enough. But Lewy body dementia is diagnosed when you have the Parkinsonism, when you have the cognitive changes, and when you have the prominent visual hallucinations, all within about a year of each other. Sometimes two, but that's Lewy body dementia. Otherwise, usually if the Parkinson's is diagnosed first, and then several years later you develop these other symptoms, it's considered Parkinson's disease dementia. And importantly, the average time to onset of dementia in a Parkinson's patient is 10 years after their diagnosis. So statistically, if you're looking at that, more people get it when they're diagnosed above 70, and then the average time to onset is 10, sometimes 15, even 20 years. A lot of people end up never getting it. So it's important to kind of understand that. You know, you're not looking at this definitive thing facing you. Another thing that's very supportive of Lewy body dementia is, and again, this is complicated because sometimes people with Parkinson's have this anyway, either as part of their disease or as side effect of medication, but REM sleep behavior issues, acting out dreams. Usually, they're not necessarily distressing. Usually it's the partner that's like, yeah, I got punched again last night. Or he attacked the nightstand. Many people who eventually get diagnosed with Lewy body disease will have had these kind of problems for several years prior to the onset of their dementia. Another very important characteristic of Lewy body dementia that's not so much an issue in regular Parkinson's disease dementia is that there are major fluctuations in alertness during the course of the day, to the point where sometimes they seem, almost comatose versus fine and almost normal back to their old selves, even within the course of a day or from one day to the next. And that's not the case in many other types of dementia. Anyone have any questions about that? I know it's a little bit complicated. So compared to Alzheimer's, which is more common, usually with Parkinson's dementia, the memory impairment is not as severe. The language problems are not as severe. A lot of times with Alzheimer's, people will have difficulty retrieving words, talking around things. If I ask, what's this called? Oh, that's that thing, and you turn on the TV with it, but you might not be able to say it's remote control. And sometimes we all do that, but when it's kind of the regular manner of speaking, is not as much the case here with Parkinson's. Executive function, as I mentioned earlier, that front part of the brain, is usually a little more impaired. The ability to sort of, plan a trip, for example, or make decisions. That's the front part of the brain, and that can be more impaired. Visuospatial function can be more impaired. It's just slower processing in general. The attention can be impaired and fluctuates. And you also can get changes in your autonomic nervous system. That governs your blood pressure, for example. People who stand up and get very lightheaded because their blood pressure drops. That's much more prominent in Parkinson's. It's prominent in Parkinson's disease without dementia, but in Parkinson's dementia, it's also an issue. So, what do we do about it? I'll talk more about the lifestyle stuff in a minute, because that's actually even more important. But we do have options to treat the cognitive symptoms of Parkinson's dementia. The one drug that's FDA approved for that purpose is Exelon. But there are 3 drugs in that class: Aricept, Exelon, and Razodine. They all are what we call cholinesterase inhibitors. They help the memory pathway by increasing a chemical called acetylcholine for those memory neurons to communicate better. And in the case of Exelon, sometimes there can be some motor improvement as well. Not dramatic, but it can help. The Exelon comes in an oral form as well as a skin patch. The reason that they came out with the patch was because this oral form tended to make people very sick to their stomach. Most common side effects of that class of medication, in fact, are stomach-related things like nausea, appetite loss, diarrhea. Obviously, if your Parkinson's makes you slower, takes longer to get to the bathroom, you don't want to have to deal with diarrhea. So a lot of people will use the patch in people who have motor symptoms.
What happens if you're on a patch for one of your other medications and a patch for this? Does that matter?
It shouldn't matter, other than the potential for skin irritation.
Okay.
With the Exelon patch, it can go anywhere on the chest, on the arms above the elbow, and anywhere on the upper or lower back, and it can rotate. So other than having red circles and not wanting to maybe wear a strapless dress, it should be fine. So the Exelon patch has become more of a choice, mainly because of the side effects. The Exelon pill comes in 1.5, 3, 4.5, and 6 milligrams, and it's twice a day. So it's very hard to get people up to 6 milligrams twice a day without significant side effects. The patch has a 4.6, 9.5, and 13.3 milligram dose, and people can often tolerate that dose without the same issues. Other things we do have to be careful with this class of drugs. One is vivid dreams. So sometimes that's already a problem, obviously, for people who have REM sleep behavior issues. So despite what some of the pharmacists say, we usually try to do as much dosing in the morning as we can, so people get the most cognitive benefit throughout the day and have a decreased chance of vivid dreams at night, particularly if they're taking Aricept or Razidine orally, which are once a day. I guess Razidine ER. Another issue is that it can slow the heart rate. So for people who already have what we call bradycardia or a slow heartbeat, these drugs can lower the heart rate by about 5 or 6 beats a minute. If your heart rate is 75 and it goes down to 70, that's no big deal. But if your heart rate's 45 and it goes down to 40, you might faint. So we do need to be careful, especially because some of the other drugs that we often give, for other things can also affect the heart rate. So we're always trying to be careful. Clearly, avoiding falls is a big deal in Parkinson's. So it's our duty to kind of not give you things that will make you worse instead of better. There's another drug that we use in the treatment of Alzheimer's disease called Namenda. Although some people anecdotally report that it helps, and there have been a couple of studies, the overall analyses of all studies of Namenda in Parkinson's dementia shows that there's not really any significant benefit. Some people try it just because maybe it'll help, but as far as data goes supporting its use, it's not there. I know that Aricept is in the midst of a phase 3 trial looking for Parkinson's, a specific indication for Parkinson's, but right now Exelon's the only one that has it. We use all 3 of those first ones anyway, though. So then we also have the opportunity to treat other symptoms as they come up. The safest class of drugs that we can use to treat symptoms, particularly when people have things like irritability and anxiety, are the antidepressants. The antidepressants, particularly what we call the SSRIs, these are things like Zoloft, Lexapro, Celexa, many others, can help from a standpoint of both reducing those mood symptoms, but also just generally helping people think a little bit more clearly, because when they're anxious, when you're anxious, it's harder to think straight anyway. So that's one of the safer choices in terms of what we have to offer. There are things that can be a problem, again, the specific things that we're dealing with in Parkinson's is we want to avoid falls. And so a lot of the medicines that we normally use for things like anxiety can make people fall down. They can make people break hips. And then we know that that's, when you have Parkinson's on top of some other thing like a hip fracture, the recovery is longer, it's more complicated. So, it's our duty to try to prevent that. So certain anxiety drugs like Xanax or Valium, we try to avoid those unless it's absolutely necessary, with the exception of the fact that one of those, Klonopin, is often prescribed in the context of Lewy body disease and Parkinson's for the REM sleep behavior issue, because it can really help decrease those vivid dreams and restless legs and stuff like that. So used carefully and appropriately, it can help, but otherwise we try to avoid.
Is Klonopin safe to use?
Yes. Yes. So you brought up a good issue earlier with the antipsychotics. There is this very delicate balance between treating hallucinations, which is seeing things or hearing things that aren't really there. In Parkinson's, the visual tends to be a little more common than the auditory or hearing things. And also delusions, false beliefs, things that aren't true, which in Parkinson's dementia often is paranoid in nature. People are out to get me, neighbors are spying on me, my husband's having an affair, somebody's taking my stuff, etc. However, she was addicted to QVC, so the UPS man was her house like every single day. And finally, one day, she confronted him. She's like, I know what you've been doing. And he's like, lady, I was just bringing her packages. And it turns out she had this whole very elaborate delusional system based on the fact that she thought he lived in the attic. And we were able to treat her with an antipsychotic, actually quetiapine, which helped and made her symptoms tolerable. It never went away. And that's another thing, because we're always looking to get the best effect without causing side effects. And when we're on the Parkinson spectrum, that balance is very delicate. So we don't necessarily shoot for making it go away. We can, with her, we got into our, okay, it happened and he used to do that, but now he's not there anymore. So she wasn't angry, it never was gonna go away that it happened, but she wasn't acting out about it, it wasn't an issue anymore. But forever she'll think that it did happen. And that's okay, as long as it's not causing her any distress. Similarly, sorry, I'm out of breath because I have a cold. Similarly, when people have pleasant hallucinations, I have one patient that I see who has Alzheimer's, but she sets a table for the people and she makes extra helpings of food for the people, and the people love it, and there's no problem. There's just usually extra food left on the plates because people aren't, we also don't need it. There's no need to treat that. It's not hurting anything. It actually, she feels comfortable with them. She keeps her physically busy, moving her body, setting extra place settings. So, her family was like, what's going on? She's not suffering any because of it. And that's true. You have to keep in mind that introducing some of these drugs that could cause motor symptoms, cause her to fall, cause her to develop Parkinsonism when she doesn't have it yet, that's something we need to watch out for. Another thing that happens, particularly with Lewy body disease, but also with Parkinson's dementia, is sort of profound apathy. A lot of people will misinterpret it as depression. Like, oh, he must be so depressed he just sits there all day. But if you ask them, they're perfectly content to just sit there all day. When that just sitting there all day is so problematic that people are skipping meals, people aren't leaving the house, people can barely stay awake, avoiding many family functions, etc. Sometimes we use stimulant drugs to help with that. There are certain ones, these are drugs that are either made for attention deficit disorder or more specifically newer ones that are used for people with narcolepsy or shift work, sleep issues because they work all night and sleep all day. Things like Provigil, for example, we can give them to people to help keep them awake and engaged during the day. Most of the people that I give it to usually kind of pick and choose the days that they need it or they're going to want it. If they know, for example, I have a lot of people that took it on Thanksgiving. So they can stay awake and, be with their families through, their turkey tryptophan-induced slumber. But, don't necessarily take it every day. But that is a class of drugs that we try to use cautiously but appropriately. They are controlled substances, so they require extra work on our part and your part in terms of refills and getting stuff to the pharmacy in the right, written properly, etc. So, we only use them when we need to. Some just key rules are to target very specific behaviors and use the lowest doses possible. Again, we really want to avoid increasing confusion, increasing fall risk, and worsening motor symptoms. So there's a growing body of research, and this doesn't just apply to Parkinson's dementia, but to all types of dementia. So caregivers here could benefit from this as well. There are a lot of non-medical things that's been going on since 1992 did show that incidence of dementia is decreasing, the prevalence of dementia is decreasing by 24%. You know, has decreased over that quarter century. Biggest thing is moving your body. Obviously, this helps you with the motor component as well. Even something as simple as taking a daily walk, doing stretching and balance exercises, you know, things that you would normally have as recommendations to deal with your Parkinson's also helps your brain because it delivers blood flow, helps get those antioxidants through your system, and helps keep your brain cells healthier. Nourishing your spirit, you know, that's different for everybody, but some people focus on big events. You should really need to focus on things, doing something every day that makes you happy or brings you joy. And for every person, that's different. You know, some people look forward to big things, but forget about the day-to-day. And people who follow this, who, you know, do something, whether it's interacting with a pet, whether it's, you know, reading a book, whether it's looking at a sunset, whether it's spending time with people you love, whatever brings you joy, doing that regularly, it increases endorphins, it decreases cortisol levels, which is stress hormone. It helps keep us healthier. Learning something new. It's never too late to start. You know, they say you can't teach an old dog new tricks. I have a Mastiff who's 12, and she just learned how to use the jingle bell to tell us she wants to go outside. It's been there for 8 of her years since she's been with us, and she finally learned how to use it. So you can teach an old dog new tricks, and you can have older people learn new things. And whether it is trying to learn a new language, learning to play an instrument, anything, you know, learning a new game, like taking on mahjong or something with strategy where you're thinking, all of these are good. I like to use the analogy, if you go to the gym, you know, you pay a decent amount for your membership, you don't just walk to one machine and do bicep curls and then walk out. Okay, so you have nice biceps, but the rest of you doesn't look very good. So you want to exercise different parts of your brain. And by doing different kinds of mentally stimulating activities, you actually redirect blood flow. And there have been functional MRI studies and other kinds of studies looking at how the brain is active when you do these things. It's impressive. Staying social, you know, connecting with family and friends, having face-to-face time with people, doing stuff like you're doing today, coming to this group and interacting and sharing with other people is very important. Eating a brain-healthy diet. What does this mean? Well, several things. One is avoiding a lot of refined sugars, a lot of, you know, carbohydrates that are overly processed. I don't ascribe to the full kind of brain hype that you hear about. That's really a problem only for people who have trouble processing gluten, which is a minority of people. But healthier carbohydrates, certainly things like rice and potatoes, things that are naturally occurring, are perfectly fine. A Mediterranean type diet that's lower in saturated fat, so less red meat, more chicken and fish, less fried foods, getting your vitamins from the vegetables that they come in rather than from a pill. All of those things can help your brain. Green leafy vegetables, fruits that are high in antioxidants like blueberries, pomegranates. There's lots of options out there, but all of those things are good for you.
Is there any indication regarding artificial sweetener?
There is a lot of data out there. There's not specific dementia data enough to give recommendations. You know, my personal feeling is I'd rather eat real sugar than fake sugar. But, you know, I don't know as far as dementia goes. I mean, we do know that there are a whole host of other health issues, from potential for cancer, certain kinds of cancer, diabetes, that actually could potentially come from those, that it's probably safer to avoid them when you can. And certainly if you're gonna have ones that are kind of distilled down from natural sugar rather than ones that are completely made in the lab. So like not pink packages.
Like Truvia or Stevia.
Yeah.
Has there been any research on some of these brain games that you can get on the computer?
Yes. There's a whole host of companies that are selling products. Some of the ones that have the most data are the Posit Science products. The BrainFit, Dakine BrainFit, they have studies showing that they actually help. Usually you have to pay more for them. If you join the Brain Health Registry, which is free, Brain Health Registry is something that one of our colleagues out at University of California, San Francisco, Dr. Mike Weiner, has started in the hopes of having, you know, people all over the country registered so that should clinical trials come up that they might be eligible for, it's easier to streamline them. But in the process, it helps create a profile of where you fit, but also offers you at least, I think it's either 1 or 3 months free of Lumosity. So it's an opportunity to at least try that and see if
What
you'd
is
like.
Lumosity?
Lumosity is another one of the online brain game type things.
Okay.
What about using agave or honey in place of sugar?
I do that myself. Well, not in this. This is pure sugar. My tea last night had agave. Yeah, I mean, those kinds of natural sweeteners are certainly better than some of the processed things.
Would that include Splenda, which really is sugar altered slightly?
Yeah, Splenda is kind of on the fence. There was some hype probably about a year ago with concerns that it might cause lymphoma. I don't know how true that is. So I did make my husband stop taking it and start using Truvia instead, for what it's worth. But I think Sweet and Low is the worst, and it's all kind of gets better from there. Small amounts of red wine. Again, when you're dealing with a motor disorder where falling is an issue, you don't want to overdo it with alcohol because that can increase your fall risk. But we do know that small amounts of alcohol, about 1 drink a day, no more than that, do have a brain protective kind of effect. Getting quality sleep, making sure that you kind of turn off screens in your face about at least an hour before you go to bed. Having kind of a regular routine at night so that your brain and body know that it's time to go to sleep. Avoiding caffeinated beverages, after dinner, certainly later, in the afternoon. And avoiding beverages altogether after dinner because then you'll have to get up and use the restroom. Minimizing noise, minimizing light and other disruptions can help. And of course, reducing stress. That's easy to say, reduce your stress. But whatever you can do, whether it's getting help from other people, whether it's incorporating relaxation techniques or meditation into your day or quiet time or whatever, finding that thing that can kind of help you just sort of relax and breathe a little bit and not worry about everything can definitely help.
Is that glass of wine in conflict with any of the medications that you have mentioned?
Not officially. I mean, sometimes there are issues, and in certain individuals there are more issues than others. And some, people who perhaps don't have as healthy liver or kidneys, where you have to be careful. It's more of an issue. There's no frank, direct conflict other than with clonazepam, because clonazepam acts on the same receptors in the brain as alcohol, so you have to be extra careful when you're taking drugs like that. That's also like Ativan, any of the drugs that have been PAM, diazepam, which is Valium, lorazepam, alprazolam, which is Xanax. Those drugs can interfere with alcohol because they work on the same receptors and potentiate each other's effects. So if you do start to notice changes in your memory that concern you, first thing is definitely talk to your doctor, bring it up, let them know, because if they don't know, they can't help. If your doctor, which certainly wouldn't be that doctor, but if your doctor poo-poos it, oh, don't worry, you're just getting older, which happens all the time. Go find another doctor, come see me. You know, because we take it very seriously, and although there are, as I mentioned earlier, things that are normal consequences of aging, you know, it's not normal to have certain complaints that many doctors write off as normal aging. There are opportunities for cognitive skills training. Not only the things you can do at home, like the online software, but there are formal programs with occupational therapists who, you know, can work on specific cognitive skills. In Parkinson's, obviously, overall slowing is an issue, and so helping you practice things that can kind of speed things up or get the engine going a little bit can help. Using external memory devices, it's a fancy word for, you know, keep a notebook in your pocket. Put a dry erase board in the kitchen. You know, if you know you have an appointment on Wednesday, say, doctor's appointment Wednesday. You know, or for your loved one, if they keep asking you, what are we doing, you know, what are we having for dinner tonight again? You know, they've done it 3 times. We're having chicken for dinner. You know, I often, I feel like I should sell dry erase boards because I made recommendations so many times that maybe I should get in on the action. But they can really be helpful, and they also help in a different way, because a lot of times, you know, if you're in a couple and you're constantly having to remind your loved one about this or that, you feel bad about it, they feel like you're nagging them. That way it's a communication center. It eliminates that sort of having that head-butting kind of interaction. You know, I told you 6 times already you were going to mom's today, whatever it is, you know.
And if they're hard of hearing.
And if they're hard of hearing as well, yes. Asking people to speak slowly and be patient with you. You know, some of you may be used to doing this anyway, just from a motor standpoint. It takes you longer to do stuff because you're slower. Likewise, you know, it's not unreasonable, you know, because, you know, we live in a society where everything's instant, you know, and I see it all the time where, you know, someone will ask a question and they don't answer immediately. No, they might, you know, oh, they don't know anything, and you just sit and give them time, and then, you know, everything comes out just fine. So making sure people understand your needs and asking them to be patient with you and speak slowly so that you can have proper time to process it, and then, you know, have an advantage. Sticking with a daily routine as much as you can, from both a motor standpoint and a cognitive standpoint, is important. Taking your meds at a regular time, getting up around the same time, eating meals around the same time. I mean, we're obviously busy, we have things in our lives that we're doing, but trying to keep a schedule can help keep our brains kind of in tune. If things get more impaired, you know, more problematic, and people are having real problems at home, you know, simplify the decor. Sometimes when there's like too much stimulation, like I don't know, well I do know who actually picked this rug, but like it's all in the medical clinic. It was a PhD scientist, it wasn't a doctor. You know, he thought it looked like neurons, which was great for a brain research center. But to patients that are confused, the can be very scary. So, you know, simplifying decor, eliminating things that could be misinterpreted. You know, there's a man stuck in the wall. That's Johnny Bird, by the way. Using night lights at night so that people can find, you know, their way around. Having that, you don't want to be overwhelmed with too much light, because otherwise that interferes with your sleep. You also want to have enough where if you wake up in the middle of the night and you're disoriented, you can easily find your way. So these are all little things, you know, that can help. These are some handy websites and where a lot of this information came from, but I'm happy to answer any and all questions you may have.
Yes, if your B12 folate levels are normal in your blood, then that's not an issue as far as affecting your brain function.
Correct. So a lot of people take B12 that don't need to. The only time it's important for brain function is if your B12 level is low. And this is actually kind of important to recognize. So if you go and get a B12 at the lab, it'll tell you the normal range is like 190 to 900. And yours might be 210. Oh, that's normal. Well, it's actually not normal for our purposes. We like to see B12 levels of 400 or above, because we know that at levels below that, people can have issues with fatigue, with confusion, with depression, and you know, they're subtle, but if you treat them, it can get better. Furthermore, as we get older, sometimes we lose the ability to absorb B12 from our gut. So B12 has this really bizarre, complicated way of getting absorbed. Our stomach secretes this thing called intrinsic factor that binds to the B12 and it's pulled across the gut wall in a specific part of the small intestine, and if any of that is disrupted, you can take B12 all day long, it won't get into your body, into your bloodstream. So people sometimes need B12 shots. I hear all the time, you know, someone will come in and have had an ulcer in 1974, right there in that part of the stomach, and they've not been absorbing B12 this whole time. And so I always bother to check it. Once we check it, we find it, we can treat it, a lot of times those symptoms will improve. But if your B12 level is normal, you know, anywhere 400 and above, taking it won't really do anything. It can't hurt you. You take tons of, you take a whole bottle a day, it won't hurt you. But it won't necessarily do anything either.
So it would take a very low level for you to become anemic? Would you become anemic at the same time?
You can be, well, those normal lab values are based on what's needed to cause anemia. So below about 190, you can get anemia or low blood count. Just like you can get anemia from iron deficiency, you can get a different kind of anemia from B12 deficiency. And it needs to be below about that 190 cutoff to get pernicious anemia.
But to take it for this reason, what was the number that you would look at, below 400?
400.
You said,
Well, and if it's like 300 to 400, you can go ahead and buy it at Publix or get the sublingual kind that melts under your tongue. It's only when it's really low and it doesn't respond to that therapy that you would need shots.
when you said the whole issue with the ulcer, it wasn't absorbing, you would know that if your levels were below 400. I mean,
And if somebody bothered to check.
Right, if you
Yeah.
checked your levels and it wasn't, okay.
Yeah.
Got it.
Is this just marketing nonsense, or is there a difference between the cyano and the methylcobalamin?
Well, both. You know, there are some who say that certain, you know, ones cross the blood-brain barrier better. You know, the people that sell you serafolin, the L-methylfolate, and the whole thing, you know, that will, it's more likely to cross the blood-brain barrier. The blood-brain barrier in humans is kind of like Fort Knox. It doesn't like letting anything in. And that's one of the reasons why we have so many fabulous, wonderful treatments that worked in mice that don't work in people. Because some of these things, you know, green tea extract and curcumin and all this stuff stuff that you can go buy in the grocery store cures mice with Alzheimer's disease, because their blood-brain barrier is like a colander, that's all kinds of things in. But that stuff doesn't cross into our brain, so we don't get that benefit unless we were to inject it directly into the spinal fluid. But that being said, you know, there's some evidence that certain molecules cross the blood-brain barrier better and therefore are more likely to have an effect.
What about turmeric? We were reading something about turmeric.
Right, well, turmeric and curcumin are the same. And that's the main issue. There's been amazing data. One of our colleagues out of UCLA did fantastic work in transgenic mice. These are mice that are bred with a mutation to develop Alzheimer's disease. And the turmeric makes the amyloid go away. But that doesn't cross into our brains. So unless we can find a way to get it into our spinal fluid, it's actually good for arthritis, so you might as well take it anyway. Or cook lots of Indian food, but it won't help theoretically. It helps theoretically, but not in reality.
The cheese tastes good.
Yeah. It's good for your joints though. Other questions?
Can I ask a question? Now that Dr. Hauser's in the room too, maybe he can play. This nice lady over here was telling us earlier when she introduced herself that she was diagnosed with Parkinson's and then went on a gluten-free diet and all those Parkinson's symptoms went away. And the first thing I thought of was, wow, why don't we all try that and get rid of our Parkinson's? Any comments?
Go ahead.
I believe that's a Parkinson's question.
Well, that's why I directed,
Yeah.
Yeah.
because it was a tremor that she said went away.
Yeah, so I'm not aware of any scientific studies demonstrating that gluten-free diets relieve Parkinson's disease symptoms. She sent me a note here that said that she wasn't sure that she has Parkinson's disease. Now, there's definitely an issue when we see a person who has very subtle symptoms, or very early symptoms, is the diagnosis correct? And studies have shown that we can be wrong up to 10 to 15% of the time in early Parkinson's disease. So there's no question that if you look at 100 of our patients that we say early on, when it's very in the beginning, we're looking with our little microscope and pulling out the magnifying glass and saying, we think you have Parkinson's disease, that there'll be some patients where we won't be correct. Now, the further along a patient is, and the more symptoms they have, the more will be correct. And the main thing I say to students and residents is, if you only have one question to ask to make sure the diagnosis is right, what would it be? And the answer is, what's your response to the most effective medication, which is levodopa or cinnamon? And if the patient says, well, when the doctor put me on it, my slowness and stiffness improved quite a bit. Or when I take it, my slowness and stiffness improves quite a bit for a couple hours and then it wears off, that's very good evidence of a correct diagnosis of Parkinson's disease. But to go back to the issue, we can definitely be wrong when the symptoms are very slight. And in that state, when a person goes on levodopa or cinnamon, it may be hard to see a response if those symptoms are slight. Now, that being said, I kind of sat here and saw that she does have a little rest tremor in one hand, and that's typically a very good sign that the person does have Parkinson's disease. Some people progress slower, some people progress faster. These days, we do have a scan that helps us look at remaining dopamine neurons that also helps us with the diagnosis. So all that said, I can't say anything about gluten-free diet. You're on it, you're doing better. That's excellent. Stick with it if it helped you. But no scientific evidence available today that gluten-free diets are helpful for Parkinson's disease patients. So if a patient asked me that in a clinical setting, I would say, if you want to try it, go ahead and try it, but no evidence for it today.
I wanted to ask you actually, talking about there's a new drug approved for the psychotic symptoms.
Yeah.
Do you have experience with that?
Yeah, we're gaining increasing experience with it. So all of the medications that we've had in the past block dopamine in the brain, or dopamine receptors in the brain. Now, those medications, these antipsychotic medications, have varied with regard to how much they block the dopamine receptors that are involved in movement. So these old classic antipsychotics like Haldol, they're quite good at causing slowness, stiffness, and tremors. So they're to be avoided, and we try to teach other doctors don't use those medications. But there's some that are called atypical neuroleptic, as you well know, that are pretty darn good at blocking hallucinations and not worsening slowness, stiffness, tremor. So quetiapine or Seroquel has been the one that we've favored for many years, and it works pretty well. But it doesn't reduce or eliminate hallucinations in everyone, and it has its share of side effects, including sleepiness. So there still is need for something new and better, of course. So this new medication called pimavanserin or Nuplazid was recently approved. It really doesn't block dopamine receptors. It works through a different mechanism, the serotonin mechanism. And based on the studies that were done comparing it to placebo, it does have efficacy when you look at a large number of patients, comparing the patients who received it compared to placebo. So we and other doctors are just beginning to get experience with it in the practical setting. We're trying to figure out just who should receive it compared to what we've had in the past and how effective it is. We've had sort of mixed results, and some patients seem to respond and some not so much. The word on the street that I'm beginning to hear is some other docs have said it seems to be helpful for mild hallucinations and maybe not the worst patients. So we had a number of patients who either were on Seroquel and still had hallucinations or didn't respond to Seroquel. We haven't had excellent results in that group of the patients who most needed something more. And as you know, the other medication that's out there is clozapine. Most patients will respond to clozapine, but that's a little trickier in that those patients need blood monitoring, and we typically, as a psychiatrist, to see those few patients with that. So pimavanserin, as best we can tell right now with just a small experience, does seem to be effective, but it tends to be effective in some patients, maybe those who have less severe hallucinations. That's what I can say.
No, thank you, because I've had trouble.
It's called pimavanserin or Nuplazid.
Nuplazid.